A very warm good evening, everyone present here. It is our pleasure to welcome all of you today to this webinar, proudly hosted by Veiva Scientific. This platform brings together an esteemed panel of interventional cardiologists from across the country to share their clinical insights, personal approaches, and real-world experiences. Today, on the very important topic of optimizing Impella therapy, patient selection, timing, and techniques. We sincerely thank all of our distinguished panelists, moderator, and speakers for joining us and giving us their precious time and expertise to this academic setting. To guide us through this evening session, we are honored to have Dr. D.S. Chadda sir as our moderator and Navreet sir as well. Thank you, Dr. Chadda sir and Navreet sir, for graciously accepting this request and steering this evening conversation. Without any further delay, I now hand over the platform to our respected moderators. So please.
Chadda sir. Chadda sir.
So I think Chadda sir is unavailable at the moment. He's fixing the issue.
Great. Thank you so much for the opportunity. I think let's not waste time. It's a wonderful device. All of us have started to accept it as a very good modality. Please, may I ask Ashutosh, are you going to start the presentation first?
Sure, sir. I'm ready, sir.
What an honor can it be that as a senior colleague to introduce Ashutosh, who's one of the finest residents we've seen, very hardworking, has spent, I think, 24 hours out of 24 hours for the last 3 years in the building of CTC. So one of the finest we have. Thank you so much, Ashutosh, to agree to present. Please present the case.
Sir, it was like Jachandra sir has given me like this opportunity to present the case in front of you, Navreet sir, Ankush sir. It's a great opportunity, sir. Thank you so much, sir, for the platform. Sir. Is my screen visible, sir?
Yes.
Yes, it is.
Good evening, everyone. I am going to present a case today of 80-year-old male ex-serviceman, in case of hypertension, diabetes, BPH, Parkinson's disease. He had an episode of ACS ST elevation entry of LMI in 23rd of November last year. And angiography was done in civil and it was found to be TBD. At that time, they have done PCI to LED with, they placed a 3 into 19 mm stent in the LED, proximal LED. After that, the patient was discharged after stabilization. In the second admission in the same hospital, he had recurrent VT. He received around 12 DC cardioversion at that admission. And after stabilization, the patient was shifted to AICTS on inotropic support. Initially, the patient was in shock, failure, pulmonary edema was there, and patient was managed conservatively. And after settling down, again, he had recurrent VT. So again, stellate ganglion block was given, sedation was given, and after that, the patient was stabilized. ECG showed QS V1 to V4, and echo shows 20% ejection fraction, and LAD territory was akinetic. This is the ECG, poor RV progression was there. And here LAD territory is dyskinetic, and inferior wall is normally normal. There is moderate MR. Here we can see the moderate MR is there. On angiography, we can see that L6, there is diffuse distal disease in the L6, and OMM also is having discrete tubular diffuse stenosis around 80 to 90%. Then LED is also having proximal, this is a proximal stent, and ISR was there around 70 to 80%. And from mid to distal, LED was disease around 80 to 90%. It is a left dominant circulation. Here we can see there is the diffuse disease in the distal L6 as well as the OMM, and proximal part of the stent is patent, but there is distal discrete stenosis around 80 to 90%, followed by distal diffuse disease. RC is non-dominant and diffusely diseased. We did a FDG PET in which we can see that there was mixed viability. There was matched severe perfusion metabolism defect in the apex and apical septum part of the apical anterior and mid anteroseptal area, but also the rest of the anterior wall was viable. So that is why after the discussion in the heart team, it was decided to go for Impella assisted revascularization. Our right femorals were having we selected the right femoral because left femoral was only 4.8 mm. So for the Impella introduction, we used the right femoral. Left femoral. Femoral we used for the Impella, and we put the Impella into the LV 3 to 4 centimeter after the aortic annulus. At the time of this introduction, the blood pressure was stable, 132/90. The patient was not on any inotropic support. After introduction of the Impella, we did the angio and we introduced the wire into the OMM, and pre-dilatation was done in the OM branch with 2.510 into 10 semi-compliant balloon. This is the IVS imaging of the OMM branch. There was distal reference diameter was 2.9 and tightest segment was area of MLA of 2.14 mm square, and proximal reference diameter was around 2.7 mm. After that, 2.75 into 40 mm stent was deployed into the L6 OMM branch, and post dilatation was done. Post stenting IVAS was done with distal strut MSA was 6.34, and initial tightest segment was having an area of 4.63 mm square, and proximal was around 6.16. Then we went to the distal L6, in where we first pre-dilated with 2.5 into 10 semi-compliant balloon. After that, TEB was done, 2.75 into 25 mm in the distal L6 segment. Then wiring of the LED was done. In the distal to the previous stent, there was the stenosis was pre-dilated, and also coming to the mid and distal LED with 2.5 into 10 mm semi-compliant balloon. We can see the muscle bridge also in the mid LED, and the distal reference diameter was around 2.68 mm. And there was in the mid LED there was calcific segment to around 180-degree calcium in the proximal mid LED, and around more than around 270 in the mid LED. Next slide. IVL balloon dilatations were done. Around 70 pulses were given of 2.5 IVL balloon in mid and distal LED, mid LED, proximal and mid LED. And after that, this stent was placed in the mid to distal LED, 2.5 into 28. Next slide. And in the proximal to mid LED, around 3 into 22 mm. And then this optimization was done with 3 to 15 non-compliant balloon. Post IVAS, after the stent deployment, IVAS stent was taken, showing distal state MSA of 5.4. Initial tightest lesion was around 3.7. Now coming to 3.7 mm MSA, and the proximal part was showing 5.23 in the overlap segment with the previous stent. This is the final result. Throughout the procedures, the blood pressure were stable, and the Impella P3 was decreased to P2, and it was taken to outer and from P1, and then the device was explanted. Sir, I want to give my following points. Like high-risk PCI is defined not just by the coronary anatomy, but by the physiology also. Severe LV dysfunction, moderate MR, and advanced age. These are some risk factors on giving it. If going for high-risk PCI, then these things are to be should be considered. Mechanical support should not be planned just on emergency basis, but should be taken support of pre-electively before the procedure. And LV unloading enables safe complex PCI, and calcium is a calcium with a diffuse calcium with enough filling ventricle requires aggressive manipulation in the coronaries, and that is why it needs safe hemodynamics. And high risk PCI is a team-based system level procedure. Thank you, sir. This was my presentation.
Chota sir?
Oh, Ashutosh, nice case. I mean, you went very scientifically from defining the viability of myocardium, which is one of the most important things to do. And case was done very well. There were few things which, each operator feels that he or she would have done differently. I would have chased the dominant circ a little because, I mean, you invested a lot in the OM, which is correct, and but the dominant circumflex could have been, once you have opened a device which is supporting your LV well, and you know that that area is viable, that territory could have been, you could have invested a little time there and done. So I don't know the kinetics of the procedure. And secondly, I'm sitting and watching here on my laptop, so I don't know because things would be different. I felt that the LED stent was not optimized very well. We see the basic dictum is when you use IVL, no, IVL kind of cracks. It cracks the calcium, but the compliance restoration is only when you dilate this vessel, you cause some dissections and separation of the fracture fragments. If you don't do that, a lot of people, what they do is they use IVL and then they take a stent. And you feel very happy that the IVL has grown in diameter. It was constricted, now it has grown. But what is more important is to use a NC or a scoring cutting balloon after that. And in any given vessel which is calcific or fibrocalcific, the luminal gain is going to be directly linked to dissections and fractures. And these fractures in the calcium plates, you have to separate them. You have to basically, fracture fragments have to move away so that the compliance is restored and you kind of get a good luminal gain. If you see the mid part of the LAT, I felt that required little more work. And once you've stented, then if you use high pressure balloons, that's like scoring with the stent element, which can lead to complications. So whenever you use these special devices, you must spend some time restoring the compliance by preparing the bed well. So having said that, it was a good case, but I feel this is how I would have approached maybe dominant circ. I would have invested a little more time and maybe I would have restored the compliance of the LED a little more.
Sir.
Yeah.
Right,
I think-
right.
And any follow-up of the patient, I am reasonably sure he would have done well with the viability on the PET and other things. So,
Sir,
you
the
have some
patient,
follow-up?
sir, at present, the patient is not in follow.
Achha.
We have to see, sir. The procedure was in December. He has not
Yes.
visited till now.
Okay, fine. Not good.
Yeah, my question was only that I think the Impella was removed slightly early. People have various different thoughts about it, but especially considering that the LED was already stunned, whatever you may say, even if it's I can see that you wanted to do the circ fast and quick and come out so that you can go on to the LED. I would have thought, some calcium modification on the left side, on the circumflex also could have been done, but as sir said, but I think any amount of even minimal dilatation or obstruction to the sole surviving vessel will cause some stunning. So maybe we could think about holding on to the Impella for at least few hours more rather than removing it on table. Most centers do it. I cannot say that my experience, but yes, one or two cases in which we did maybe a little longer holding on to the Impella for 12 hours, 16 hours. The logistics are always difficult to maintain Impella longer. So, but I think my quote would be that we should take him to ICU and probably remove it that evening or maybe the next day. Because as such, the Impella is designed to help you for 2 to 3 days minimum, ideally 4 days. So why not hold on to it till everything becomes well again?
So, right, sir.
So, sir, it was decided on the table after a discussion. The patient was hemodynamically very stable, and we thought it will be difficult to manage him in the ICU with the Impella, and he didn't go into failure because sufficiently diurized prior to the procedures, and his cardiac index was perfectly fine. So it was a kind of a team decision to take the Impella out. Gradually was weaned off on the table. Despite weaning, he maintained good hemodynamics, so we thought that we can get away. And patient remained very fine after that, sir. He didn't have any failure or anything overnight. He spent another 48 hours in the hospital, 72 hours, and he was discharged in a stable condition. Yes, and the thing is that he underwent a PCI to LAD before coming to us with a recurrent VT storm. He was shocked 22 times. He was almost a very octogenarian, and yet he could stand that multiple shocks and insult to the myocardium. And he gave us a window in which we could kind of take him up. Otherwise, either he was having VT or he was going into LVF. So we had a window and we seized the moment. We slightly kind of kept him on a negative balance for 2-3 days and took him up. So, and the OM was coming very close to the ostium of the LCX. So, and OM was going all the way till the apex, and circumflex looked like a little smaller. So, nevertheless, we addressed both the vessels. And LED, I think the stent was already there in place from the civil hospital, which we had to kind of cover up the distal and proximal portions. And that stent was under expanded probably because of calcium. They did it in a hurry during PAMI, and probably the stent didn't expand. So we had to give some shock within the stent also. Probably that we couldn't post-dilate very vigorously. That's why we didn't have a very good result in the end. But patient was pain-free, hemodynamically stable, and he spent next 3-4 days without any requirement. And this patient, we had to do a lot for him because we had even given a cervical sympathetic ganglion ablation with bupivacaine because he was having VT storm. And whatever other time he spent was either in failure or in VT. So even we were deciding why to use an Impella on such an elderly gentleman, but he did earn it because he spent almost 3 weeks in the hospital, and yet he had a smile on the face. He was unwavered by what all was happening to him. So we thought that this is the ideal person, and he's a veteran, no doubt. So he deserves it. So that is the thing. So that's a learning, sir. I mean, we have all done it as a team, and we did take some decisions together.
My question to all the panelists and especially Chetta sir, have you ever used Impella as a bridge to a PCI? I mean, put a Impella for 24 hours, let the patient stabilize a little bit, and then take him for PCI. Have you done that ever, sir?
No, I've had IABP because, but not with the Impella. Because this basically stands to reason, and there is a lot of literature supporting this. How it helps is it helps you, Impella in true sense unloads the LV. And the moment you unload the LV, that reduces the transmyocardial pressure. So your coronary perfusions improve, your irritability of myocardium comes down, the ischemia comes down in the myocardium. So LV can cope up very well. So there is one paper by, I think by Nikhil Chopra, someone from US, who talks only about this, unloading the LV and then taking up the patient for revasc.
In fact, that has now become
more in cardiogenic shock secondary to STEMI.
So in fact,
Not
now
for chip
we're
cases.
trying to do it even without cardiogenic shock. Impella in MIs just to unload
LV.
before the patient actually goes into cardiogenic shock.
Yep.
But मेरा ये था कि sometimes the patient is so unstable. Though the Impella gives us that great advantage when it gets that uncoupled to show that really the heart would have settled, gone down had we not used it. But I just always think that could we unload for a few hours at 6, 8, 10 hours,
Absolutely.
improve renal perfusion a little bit, and then go on to do a PCI. I don't know whether it's been ever done or not.
So that's been practiced with IABP. I've done it with IABP during my stint in the forge as well as in civil feed. That you can put an IABP, that helps you. The unloading is not as great as with the Impella, but that really helps you then get in because the hemodynamics are much better. Coronary perfusion is much better. And regarding taking out Impella, whether on table or this thing, when I give my talk, I'll give you my thoughts on it as to there are some objective criteria which you can use, rather than taking ad hoc decisions. So there are some objective, well laid out criteria which can dictate whether you need to take it out immediately or later or whatever. Right.
Next up is the talk or is the case presentation?
No, there are I think 3 cases. So next, I think I don't have the list in front of me.
Sir, Dr. Monga will present next.
Okay. Indrajit, you can share your slides.
Yes, sir. Good evening, sir. I'm just sharing screen.
Because we are all friends, I can tell you this is the finest turban of Monga I've ever seen. all friends I can take.
Thank you, sir.
So Monga, before you present, you get a compliment.
So thank you, sir. You are all my mentors, sir. I'm really grateful for this opportunity that I'm getting to present this case, sir, in front of this august audience and sir, all my mentors, sir. Sir, this is a case of complex ACS intervention, which was done under Impella guidance and Impella support and OCT guidance. I don't have IVUS here, sir. Sorry, sir. Again, screen is. Yes, sir. So this is the patient, sir, we are done in workshop, sir. This patient was done in workshop. It was guided by none other than Chadha sir only, sir. And he was there to support this patient, to support us, sir, for this patient's intervention. So this patient is 60-year-old male, known case of COPD, CKD stage 4, non-oliguric, with creatinine of 2.3 at the baseline and hypertension and diabetes. Sir, and sir, he suffered a non-dissolution MI 20th of July, sir, and this angio was done on next day, sir. That is on 20th of July, 21st of July. EF was 20 to 25%, and patient had distal IVS and apex akinetic. The angiography revealed triple vessel disease. Left main was distal was 80 to 90%. LAD was ostial 95% with the tubular disease, and thereafter, and mid to distal, it was a diffuse 90% with diagonal disease also. So, and LCX also had ostial plaque with distal 95% and diffuse disease after OMM. And RC had, which was dominant vessel and had proximal to mid diffuse around 90 to 95%, but it was calcific vessel. So we had done, sir, first given this patient to CABG and referred this patient, but in view of severe LV dysfunction, frailty and other comorbidities, he was rejected for CABG. However, our CTOS team was standby. Sir, and PET scan was done before taking up the case. So which was showed hibernating myocardium in the LED and LCX and RCA. All territory were viable. So we had planned this case when Chadha sir was coming for workshop, and it was done under an OCT guidance. I was being assisted by Lieutenant Colonel Ajay Pandita, sir, my colleague, sir. Sir, this as per this flow chart, for the high risk case Impella selection, so our patient was coming to total score of 7 So it was recommending that we should have strongly consider this Impella support, because EF was less than 25%, patient renal dysfunction, ACS, he was turned down from surgery, and this was unprotected left main intervention with triple vessel disease with a large area and viable myocardium. So after this Impella support was considered, and through the left femoral, the Impella was inserted. We didn't have any problem in that, sir. After that, sir, we started the angiogram, sir. We hooked the guide with 7 French EBU, sir. And after that, this was the initial angiogram. And we showed distal left main disease, as well as there is a ostial LAD. And after that, diffuse disease in the LAD, sir. Mid and then the distal part, sir. And L6 is also a disease after, firstly, there is a plaque in the ostium, and thereafter in the distal L6 after the OM branch. This is a diffuse disease. So first we did the wiring. Wiring was placed and both the vessels were secured. And after that, we started the pre-dilatation. First, ostial LAD was pre-dilated. And after that, ostial L6 was also pre-dilated. First with the NC balloon, 2.5 into 15. Thereafter 3 into 13 scoring balloons were also used, Aperta balloon, for the bed preparation. Thereafter, we did the OCT also. OCT pullback was also taken. So we didn't reveal much of the calcific disease in the LAD, and it was a calcific, fibrocalcific plaque mainly. And in the ostial L6 also, area was good, around 4.77 square. This is after pre-dilatation, sir, of both the places. And after that, sir, we did the DEB in the distal part of the LAD. And after that, again, after further bed preparation, we stented this portion of the mid LAD. Focus stenting was done in this area. After that, we fixed that distal L6, again first pre-dilated with the balloon, and after that, it was only DEB was done, because this was distal vessel and small vessel. So stenting was not considered in this patient, sir. And after that, crossover stenting was done from left main to LAD 4 into 16 millimeter. Megatron was used. And we can see that despite bed preparation with 3 into 13, there is an under expansion here, sir. So it was post-dilated with the 4.5 into 8, and port was also done with the 4.5 into 8 mm NC balloon. And thereafter, OCT run was repeated, which revealed both distal and proximal stent had under expansion, sir. Significant under expansion. This was 67% in the proximal stent, as we can see. And distal stent also had under expansion. MSA was also less. Minimum stent area. So after that, sir, we further pre-dilated, and first the distal part and then the proximal part, both were pre-dilated, and post-dilated, both were post-dilated with the bigger balloon, sir. Both distal and proximal stents. This was the final result, sir. After, and OCT was not repeated because patient had already had severe LV dysfunction, so we were taking care and giving 50 to 50 dilution OCT, sir. And thereafter, we fixed the RC in the same sitting, which was proximal to mid. There was a diffuse disease here. There was a calcification. So again, both scoring and NC balloon dilatation were done. And after that, since hardware was not going, so we had to use this guideline support. So with that, we could cross and we could do the bigger balloon dilatation and bed preparation. And after that, stenting was done, sir. And again, it was done with the guideline support only. 2.75 into 24 mm stent was deployed. And thereafter, it was post-dilated again with the guideline support. 3 into 10 mm NC was used. This was the result after post-dilatation of the RCA. After that, patient was shifted in the Impella only into the CCU and with the Impella support only, but it was reduced to around P8 to P7 level. And we had documented multiple times uncoupling during this balloon dilatation, especially in the left main and the ostial LAD. And this was one of the screenshots we took from the when MAP was being maintained by the Impella support, but LV pressure was falling and as well as aortic pressure was falling. So our cardiac output was maintained throughout with approximately 4.1 liter per minute throughout by the Impella support. Thereafter, patient was shifted on ICCU on P8 level of support, and thereafter cardiac output was measured, and every hourly we were reducing by 2 P levels. And thereafter, patient was brought back again after 3.5 hours, 3.5 hours into the CCL. And when he was on minimal noradrenaline support and native cardiac output also improved, and cardiac output, cardiac power output was also improved. So MAP was 88 at that time level. And on P2 level, we removed the Impella thereafter. And patient was again observed for another 48 hours. And at the time of discharge, his creatinine was 2. So after this was after removing the Impella, sir. So take-home message from my case is that Impella system helped in managing this surgically turned down complex and high-risk indicated ACS patient with severe LV dysfunction, and complete revascularization could be done in the same setting. So this patient is symptomatically improved and angina-free, and we have done around 6 months of follow-up till now. And follow-up echo was done firstly on 11th of November, and now just a few days back, 24th of January 2026, his EF has already improved to 45%, and he's in NYHA class 1. So prior risk assessment scoring is useful in proper selection, patient selection. Like in this patient, we opted for Impella support, and clear communication during or throughout the Impella insertion and following the weaning protocol is important. So don't be hurrying weaning. As in this case, we had to wait for around 3.5 hours till the time native cardiac output improved, and thereafter only we removed the Impellas. This was the team, and this was the patient, sir. And these are the cardiovascular CTVS team, sir, cardiac surgeon and anesthetist. We are all there, sir, for this patient, sir. And overall, over and above, sir, Chadda sir was there, sir, sir, for guiding this patient, sir, throughout the journey of this patient. So this was my case, sir.
Great. Awesome. I just have a question. When you
Sir.
don't have, how do you assess that you have crossed the aortic valve fluoroscopically well?
Sir, is the Impella, sir? There is a fluoroscopic marker, sir, which we have to keep at the.
How do you know where the aortic valve is?
Sir, where the aortic valve, sir. We have to. No, sir, through the current, motor current also, and the other features also like LV and aortic pressure waveforms. We can get, sir. The aortic waveform should be optimal, and then pressure waveform also signal should be this for the LV also should be there, sir, and with the LVDP also being recorded, and simultaneously motor current should be, sir, this thing. All three things we have to see, sir, on the screen.
Okay. No, my only point is I've always been in doubt.
Sir.
How deep am I in the LV with this thing? Just fluoroscopically. Is there anything that you have, sir? Because
I will tell you the role of echo, which plays a very important role, and I'll show you a couple of slides on that, because I'm going to just focus on how and when and how you should use basic learning, playing with the screen, functions of each and every component of the device as to how what is to be done, because I think that understanding is very important. Inderjeet, I don't remember this case at all. But having seen the case, I think IVUS is always better. But if you have used, and that too in a patient who has got renal dysfunction, so I am not very fond of saline in left system. So I think you would have seen that I must have restricted my number of runs. I have cases in renal dysfunction where distal left main 2 stent I have done with 30-40 ml of contrast using OCT. You take one run, you get all the dimensions, then you start working without checking in between. And that's what we would have done, because I didn't see you play so many runs, because it would have been just pure stent deployment and post dilatations.
2 pre and 1 post, sir.
Yeah, correct. So
IVUS is not available with us, so we could not.
So I mean, if you left main one should use imaging, so that would have been the premise. And I think very strongly advocate provisional stenting, and that's what was done, and it has held its place. So about Navreet's point, I think when I come up with my talk, I'll show multiple ways as to how you get to know the optimal Impella positioning, which is very, very important. Very important. Otherwise, you keep getting alarms, and there are situations, because when the blood is being pumped out, and if there is a slack in the device, it will dive in. It will dive in, and your position will change. So there are few things which you have to be very, very particular. There should be no slack in the device. How does one shift And when you shift, what all you have to monitor. And it's not mandatory that you get the patient back to the cath lab for closure or for removal. You can remove it in ICC only. You need not get the patient. These are things which where you'll develop confidence as you'll use more devices. So,
Yes.
and how does one change the P levels? What is the protocol followed? So I will speak on all of this in my talk.
Sure.
It definitely is a device which is expensive, of course, but it makes you comfortable, and it makes you take the call. And I mean, the patient benefits a lot, and you can peacefully, without your catecholamine surges, you can finish the case peacefully.
Very right.
So,
Thank you, sir.
if there are any other points, Sanjeev, Jayachandran, Anil, all those
I
who
think,
are
sir, the third case
Ratish.
by Colonel Abbott,
Yeah.
it will amplify, sir, the last message that Inderjeet put in his slide. Do not be in a rush to remove the Impella. It is something that really cuts down on the catecholamine surge of both the doctor and the patient. We are kind of afraid that Impella being inside will cause a problem. I think we are in a rush to move it out. Anil's case will also possibly highlight the same, that Impella is a good thing to have inside. It's a good thing to have inside. Sir, Anil is on screen, sir. I think Anil is the last.
I think Jayachandran wanted to say something.
Oh, right. Sorry, Jay.
Jay, if you want to add.
So there are so many indications, but because of the paucity or the cost factor, so we select certain cases which we that probably we very high risk on the table. So most patients who are coming with MI and cardiac needs, some were able to bail out with quick procedure, inotropes, targeted kind of PCI, not kind of overdoing anything, but only in certain cases, because there are one or only two available. It's a luxury. So we really choose our patient, and the patient which is continuously not able to get out of the ICU. We are unable to take him on the table, or we are unable to get him out of the ICU. So these are the patients we are selecting. But otherwise, I know that if it is available, if the cost is not an issue, it would really aid in so many other complex PCAs we are doing, and it will benefit.
That's a very good point which you're making, Jay. I'll tell you, when I was in Forge and TAVI was just being launched, so I went to the deputy commandant and said that, okay, we'll buy a valve, we'll do a valve. So he turned around, gave a smile, and he told me, see, Chadda, one TAVI is equivalent to 6 months of insulin for my dependent population. I just shook hands, smiled, and I came out. The point which you make is very pertinent. We have to utilize our resources judiciously, and the case selection has to be, just because device is available, it should not be used. Case selection has to be good, and the benefit, because this is one device which does not go with the patient. It's a bailout device. It's a device which kind of gives you hemodynamic support, and then you take the device out. It's an expensive device, so you have to be very judicious in using the device, and you have to select. Your case, which had refractory VT, and I don't know how much of stunning 22 shocks would have done to the myocardium, because that kind of roasts the myocardium. Getting 22 shocks will cause severe myocardial depression by itself. So that is, I think, as you rightly put in your words, that the patient earned the device.
But point well taken, sir. We should, next time we'll try and keep the device for a couple of, at least for 24 hours before we.
No, I'll tell you about that. There also, that varies. It is not that all of the patients you have to keep for 12, 16, 24 hours. In chip cases which you are doing, and the hemodynamics are fine, and you'll see a pressure crossover of native cardiac output and Impella assisted cardiac output. There are curves which come. The white curve goes up. That means his native cardiac output is climbing and is normal as you're bringing down the P levels. You just take out the device on the table. You don't need to keep the device. It is not that keeping the device is going to help you. And if you follow the IFUs, there are fixed number of days given devices can be kept, and because it causes complications. It can lead to DIC, it can lead to other problems. So it's not that it can, and if you look at the danger shock trial, the only thing which pulled the device down was the peripheral complications. You don't know what the limb anatomy is like. You put a big device inside, he can develop distal gangrene, he can develop a lot of groin complications. And if you're leaving devices for long, I will show in my PowerPoint that you need to perfuse the limbs. You need to see that the limbs don't turn cold. You need to keep checking ACTs. So, but yes, you are up against the wall, but it is not mandatory. If you do a chip case, hemodynamics are good, pressure crossover is fine, your PAPI is good, your cardiac power output is good, just take the device out and do a groin closure, because that secures and it has done its job.
Yes.
True, sir.
Thank you, sir. Yes.
All right. So we can have now Anil's case.
Good evening, everyone, and thank you so much, sir. It's an honor to be presenting in front of the stalwarts of Armed Forces cardiologists, and I'm thankful for this opportunity also. So without much further ado, I think I'll share my screen, and we'll start with the case that we did. Sorry, I think, is my screen visible, sir?
Not
You
yet.
are visible, Albert. But
Okay.
Yeah.
Now the screen is visible?
yes.
Yeah.
But my controls are not working somehow. Yeah. So,
My controls are never with you. Controls are with HOD.
So this was one of the cases. At the outset, I must thank that time Colonel Ratish sir was the HOD, and Ratish sir and Praful sir had done this case, sir. This was a 52-year-old male, father of a serving soldier. He had presented with ACS. He had left main and TVD with severe LV dysfunction. EF was barely 25-30%. He had severe MR. And to top it up, he had had a recent stroke around 2 weeks back. PET CT was done, which showed hibernating and viable myocardium, except for the apex. And we did an angio. His left main was diseased. LED was an ostial cutoff with no channel visible. L6 was a non-dominant vessel, which had diffuse almost 70-80% disease. Ramus was a fairly large vessel, again 80% disease, and RCA was also cut off. So this was the situation, and in view of the recent stroke, poor EF, the surgeon said that they are not going to offer him a CABG. So we thought, okay, we'll try and do this. So this was taken up, and when we did the assessment, as Indrajit sir had shown the chart, this patient also had a score of more than 5, which meant that a supporting device was warranted for him. And fortunately, we had Impella at that time, so we said, okay, we'll go with Impella. So in our patient, his EF was poor. He had severe LV dysfunction. He had severe MR. He had a left main disease, and there were 2 CTOs, LED as well as RCA. And to top it up, he also had a recent stroke. So this was his echo. We can see that except for the L6 territory, rest of the territories were barely moving. He already had a dilated LV. Severe MR was there. So we thought that, okay, first let's try and open up the LED and RCA CTO, because the CTOs will try and open up first. So we had decided that we'll go with an upfront Impella. His right femoral had some disease, so we went with the left, and we took a single vessel approach. So we put the Impella as well as the guiding from the same puncture. So first the Impella was put from the left femoral. And what was discussed in the last case, that one of the ways of doing it is that we can keep a pigtail at the aortic annulus, and then that can give us the position of the aortic annulus, and that is where we place our fluorescent marker if we want to be sure where our Impella should be. So single axis technique was used, as I already discussed. And so the Impella as well as our guiding catheter of 7 French went via the same axis. So this was the coronary angiogram, what I told. So the left main, we can see there is a distal tapering of the left main, significant disease. LED, we can't see any channel. It was completely cut off. Ramus was significantly diseased as well as the LCX. So we tried with multiple techniques. Wire escalation was done, but despite almost, I think we tried for an hour and a half plus, but the LED CTO we were not able to open up despite whatever efforts we did. And the good thing is that because the Impella was in place, so for whatever time we were at it, fortunately there was no hemodynamic compromise as far as the patient was concerned. So as we can see, our wire did not cross into the true lumen. So then finally we decided that okay, we'll abandon the LED, we'll leave it for now, and then we focused on the RCA, which fortunately with the wire escalation techniques we were able to cross. And then the RCA, the preparation was done. We pre-dilated the RCA and then deployed three long stents, in fact, ostium to distal, all three, the whole of the RCA was stented. But after the procedure were done, you can see this again, we also recorded a few instances of VA uncoupling where we can see where the arterial pressure is being maintained, but the LV pressure is going down. So this is one of the good things about Impella, that when we are doing ballooning in a critical, let's say, unprotected left main or a single vessel, so at that time the LV is not receiving any blood. So there is a sudden fall in LV pressure. But fortunately, if the Impella is in place, the pressure hemodynamics are maintained. So that is the good thing about using this device. So, but we found that on the check angiogram, we did not get that good a flow. The flow was TIMI 2 kind of a flow at the end of the procedure. So we called it a day at that stage, and the Impella was left in situ. So then we said, okay, we'll observe what happens. The patient was shifted back to the ICCU on Impella with the RCA being opened up, and the left system was unaddressed at that moment. So the patient was on Impella support for 2 days thereafter. The ACT was maintained. He was on UFH infusion, distal limb perfusion, as Sir had rightly pointed out, that when we are keeping Impella for a long term, there are a lot of things we have to check. We have to check the urine output. There should be no hemolysis. Lactates have to be measured. ACT has to be measured regularly. And rest of the things we monitored. And fortunately, there was no complications during this phase when the patient was on Impella in the ICCU. So Sir is going to discuss that, so I'm not going to spend much time here. So coming to stage 2, after 2 days, we found that the first reassuring thing was that the flow in the RCA had improved. It was almost TIMI 3 flow now. So now we directed our attention back to the left system. So this time we did not chase the LED CTO. We had tried enough, and therefore we did not attempt LED CTO this time. We simply wired the Ramus and the LCX, ballooned both the vessels properly, and then went with a single stent from left main to Ramus, and deb was done across the LCX. The LCX was opened up nicely, and then you can see that the kissing was also done, and these were the final shots. On the right, we can see. So this was the final result that we got after kissing and everything. So the ramus opened up nicely. There was a little bit of dissection in the L6 ostium, but we did not, we said, okay, we are going to, it's a non-flow limiting dissection, and we did not want to stent it. So we left it at this. And this was the final IVUS run. In the on the first time, we had not taken any imaging, but in the second instance, the patient remained hemodynamically stable. So we did do IVUS both pre and post. These are the post images. We can see the ramus the stent was well expanded and the left main was well covered. And similarly, the LCX, we can see the dissection flap near the ostium, and then the the left main can be seen. The left main has opened up nicely, as well as the ramus. L6, of course, there was a little bit of dissection at the osteoproximal segment, but we accepted the result. And thereafter, the patient was shifted again back to the ICU on the Impella itself. He was kept on Impella for another 24 hours, and then he was weaned off gradually in ICU from P9 to P3. He was maintaining stable pressures, and then from once we got to P3, then we explanted the Impella in the cath lab itself. Though, as sir has rightly pointed out, it can be done in the ICU also, but then we didn't want to take any chances, so we got him back. We took out the Impella, and then we closed the left femoral axis with a ProGlide and a AngioSeal 8 French. So this is our total cumulative experience for the Impella cases so far. From January 23 to 26, we have done 11 cases of complex PCIs with Impella support, and technical success was achieved in all the patients. There was no challenge in implanting Impella in any of the cases. Complete revasc was done in 9 cases out of 11, and partial in 2, including the one which we just saw, where we did not chase the LAD CTO. And outcomes, so the survival at the end of 30 days in our patients in 9 out of 11 cases, which is to the tune of 80% plus, which is a big advantage over the patients with cardiogenic shock, where the survival is only to the tune of 50% or less at the end of 30 days. So definitely this device helps patients, provided, as has been already brought out, that if we do the correct patient selection and we monitor them properly, we should be able to improve outcomes. In fact, maybe I don't know whether, but in one of the cases, in fact, it was a young serving soldier, and I still feel bad about having lost him. He was one of the toughest cases that I have come across in my brief career so far. He had a LAD, which was a thrombotic cutoff, an RCA, which was a thrombotic cutoff, and there was a L6, which was flowing with a thrombus floating inside the L6. So this case was one of the 2 mortalities we had, despite being on Impella. And I'm just thinking that maybe, we are wiser in hindsight. So this was a patient where we started off with IABP, and after, doing the procedure, then we put the patient on Impella. Maybe if we had started with Impella front, maybe that life could also have been saved. I don't know that. That is just conjecture, but I don't know. So takeaway message from my side, that mechanical circulatory support is a key component of patients who have complex coronary artery disease. And if the criteria are met, then rather than waiting too much, we should initiate mechanical circulatory support early. And definitely Impella support improves outcomes in patients, as our experience has shown so far, as well as world over also. This is the only device which has shown any mortality benefit in cardiogenic shock and revascularization, or over and above revascularization. And also it leads to recovery of LV function. The patients who are on our follow-up, most of them have shown recovery of LV function also, including this patient. So that is, I think, something which is important. So that is all from my side, sir. Thank you so much. And
very nice case, Anil. And I think case has been done very judiciously. You have staged the case rightfully, and so those who are involved in the decision making, they have kind of factored everything, and very scientifically you've gone about and illustrated very nicely how a complex case has to be handled and done. Having said that, I feel that the only thing which could have been done, maybe one gets consumed in the process, is more proactive use of imaging. So whenever I meet Ratish next time, he's going to be kicked, even though he says he's doing a lot of dialysis these days. So we've spent.
Sir, yeah, images I have not put. Was done. Was done.
This is in a lighter vein. This
Sir,
is in a lighter vein. So, but a good case and some good decisions of staging and coming back, because there is something called operator fatigue, and that is where the problem starts. You get consumed, and CTOs are unpredictable, and no one can say that you will be able to open up a CTO. So we all know that you get consumed. So, but uh, a nice illustration. There any other points from the co-panelists, Navreet, Jayachandran, Sanjeev, Indrajit, all those who are there, and
No, I think wonderfully staged procedure. As Sir said, imaging. Maybe I would have tried to open the CTO of an ostial LED, which I cannot see. I don't know how. I've just seen it done it 3-4 times by using an IVUS. I think you can sometimes the ostium thoda dikh jata hai, so you can poke with a slightly harder wire on a micro.
No, ostium had been crossed, sir, but we could not cross the distal channel. I had shown the images also. So yes, sir.
But I think the Impella support, this is
It worked wonderfully.
exactly what I was asking.
Sir.
Can we put a patient on Impella first and then wait and then do the procedure? I think partial has been answered by you actually doing it and showing it that yes, we can let the patient improve on an Impella and then go back again and do it.
Thank you, sir.
Hats off, Ratish. Wonderful, yeah.
It's just a teamwork, sir, and everybody is actively involved. It was good. He survived because after the RCA stenting, he had almost crashed, and it was just the Impella which saved the patient. Otherwise, he would have 100% dead.
So the good thing about RR is that everyone jumps in.
Yeah.
There are no days, there are no primary operators. Everyone is an operator. Everyone jumps in. And teamwork, as Ratish points out, he's left behind a very good team for me. So the teamwork is actually what brings out a patient back from crisis.
Excellent. Excellent. Chadha, sir.
Thank you. I think, can I start my presentation so that?
Absolutely, sir.
All right, fine. I'll just share the screen. I've got some problems. Wait a second. Is it?
It says that you started, but it's not come on.
Okay.
Yes.
Are my slides seen?
Yes, sir.
Okay. So I'll just share a few thoughts about when and how to use Impella. And I think everybody knows about Impella, that it's a microaxial pump, and you can use it on the left or the right side. I have not used the right-sided Impella till date. It comes in 2 configurations, as you can see now reflected on the right side of the screen. So generating flows of about 4 liters. It's basically sucks the blood from the RV and throws into the PAs. Where the left-sided device, we have Impella CP and Impella 5.5. Impella 5.5 is a bigger device, and they're both Smart Assist. Smart Assist means that they collect real-time hemodynamic data, and they help you in precisely carrying out the procedure. That means it includes positioning and this thing. These are the catheters. I think everybody is familiar. I'm not going to spend too much of time on this. Everybody knows how to put in an Impella. That's not very important. This is the screen which comes on display. And once you've inserted, you get to know that the Impella position is okay. There are certain buttons, and these are all smart screen soft buttons. So you have some mute alarms, flow controls, and you have purge menu. You have the purge disc, which is there. I'll talk about each one of them, and the purge cassette door. So each component we'll talk. And once you've started the procedure, then this is what comes on top. That means if I've inserted the device, then I get this screen. So what all is displayed in this screen? You have the catheter serial number, you have the system date, you have the AIC serial number in the software, and then you have certain controls like the power, whether it's working on a battery or it's got a power supply. And there are certain soft buttons for the flow control display, purge menu. And you have a central display. We'll talk about this a little later, which tells you the aortic and left ventricular pressures, and it gives you the motor current. It talks about the flow area, where you get to know how much flow is being generated. The purge system, as to what exactly is this purge system and what's its role. And then you get to see the cardiac power output and the total cardiac output, which is available to the patient. Now, these are the things which you get to see on the main screen. Now, this device is nothing but a rotating impeller pump, which pulls the blood out of the LV and throws it into the aorta. And as you keep increasing the speed of rotation, the flow rate keeps increasing. Now, when you have a pump, there are chances that when it is working, the blood can get into it and the blood can clot in this pump and stall its function. So you need to purge it. So that's why we have this purge cassette. Now, purge cassette's basic role is that you must have seen that they set up the device, they put some solution. Now, this has to be a 5% dextrose. Now, why 5% dextrose? Because 5% dextrose is acidic and it prevents the coagulation. And if you use saline, that saline is supposed to be corrosive. It can corrode the pump, so there can be problem. So now the basic pump, the function of the purge cassette is to purge blood into, if you see these, I will just activate the pointer. So if you see, this is where the purge flow comes, and this purges the pump because it prevents the blood from getting in, and the purge fluid prevents the corrosion, prevents the clot formation, and the delivery rate is from the purge fluid delivery rate, which is heparin with 5% dextrose, is about 2 to 30 ml per hour, generating pressures of 300 to 1000. Now, this flow rate is automatically determined and is directly linked to the pressure against which the flow has to go. So if the pressures are high, your flow rates and the purge pressures are going to be on the higher side. This is just for your understanding, so that when you see this, that there is some purge pressure or purge flow rate, both are displayed, mentioned, and this is what it is. So this is how it comes. So in this given case, the purge flow rate is 7 ml per hour and the purge pressure is about 600 millimeters of mercury. You have little to control, so this is all automatically controlled. Now, if one looks at the indications, so the indications could be cardiogenic shock because of ACS, or it could be any chip case which has come to you. You know, these are broadly the indications where you need support of this device. That means advanced age, frailty, diabetic. These are the comorbidities and the hemodynamics, and you have complex coronary anatomies, as we saw in the case examples, mainly left main CTOs, bifurcation, sole surviving vessels. Now, this is an Indian paper where the consensus document, and I think everybody is aware, and I was very happy to see that everybody was sharing this document. So there are some contraindications. There are certain situations where we don't use, and this is pretty obvious. Anything with LV thrombus, you would not put a catheter into the LV. Mechanical AVR, because you can't go through this. Moderate to severe AR, because you are going to compound the problem and the AR is going to increase. Ventricular septal defects, severe peripheral arterial disease. Now, the axillary pumps can be used if you have peripheral arterial disease not involving the axillary arteries, which are quite resistant. So you can go through the axillars. Severe right heart failure, you need a RV support, but in right heart failure, it doesn't work. Now, AS is becoming a relative kind of contraindication because you can always balloon dilate and put a pump inside. There are a lot of case reports, and we've also done one case with that. Now, we know that when you have a patient coming with hemodynamic shock, we are all very fond of inotropes, noradrenaline, dopamine, all pressors are being used, but you also have to fall back among the devices. And these are the devices which you can use, IBP, tandem heart, ECMO, and Impella. So the basic thing with the inotropes is that if you keep increasing the dosages, and this study in 99 showed that with 3 drugs on high dosage, you can see the mortality keeps climbing up. So as the inotrope dosages are increasing, the mortality is definitely going to be going to go up. It's like whipping a lame horse. It's not going to run. So under such circumstances, when the inotrope requirement is going up, I'm not going to the cardiac loops, but the hemodynamic support becomes very, very important. So MCS devices are very important. And if you look at the MCS devices, what they do is that they provide circulatory and ventricular support. And this is what Navneet was hinting at, that when you put it preemptively, if you put a device inside, it unloads the LV, so that reduces the LV pressure. Circulatory support means that the mean arterial pressure gets better, so the cerebral renal perfusion gets better. And most importantly, the coronary perfusion is better because there is increased transmyocardial perfusion. Now, if you look at IABP just increases the mean arterial pressure and a little bit of coronary perfusion. It's a weak device. It's the flow rate max it achieves is about 2 liters or so. Now, ECMO essentially is VA ECMO one uses. It kind of gives a good circulatory support, helps in oxygenation, but it increases the LV afterload because it increases the LV afterload. So not a very good device to be used if the lungs are not affected for doing elective procedure, because the LV afterload is very, very high and it does nothing to the coronary perfusion. Tandem heart is too aggressive and too expensive. Impella is one device which is very easily implantable, and you get a green tick in all the 3 boxes. That means you not only increase the mean arterial pressure, you reduce the LV, you unload the LV, and you also improve the coronary perfusion. A little busy slide, but all I want to tell you is that the failure can be LV failure or it could be biventricular. Biventricular failure, we say once the PAPI score comes down. PAPI is nothing but your pulmonary artery systolic, diastolic difference between these two by the mean pressure, and the figure if is less than 1, that means the pulsatility or the coordination between the right ventricle and the pulmonary artery is gone. So pulmonary arteries are no longer pulsatile, so there is no oxygenation happening. Under these circumstances of biventricular failure, either you use LV and RV Impella, or you need to go on and do something more. Now, this is a very good slide and I'm very fond of it. It helps you select the support system in a resource-stretched environment. So if you have a very simple anatomy, ostial midshaft or a single stent strategy, if the EF is less than 20%, you can choose either IABP or Impella. IABP is good enough in the EF section of 25 to 35%. And if the EF is more than 35%, just put a sheath on the right side so that if you see that you need to convert, you can convert. As the complexity increases, the role of Impella increases. Now, complexity, mind you, is also determined by the operator's skill as well as the patient's paying capacity if you're out of Forge. So, I mean, if someone can afford outside, you offer the therapy even for a little less complex disease because it adds safety to the procedure. This is an honest submission. So device, essentially, everybody knows, I'm not going to go into this. Basically, it unloads the LV, reduces the oxygen demand, and increases the coronary flow. So the blood, when it comes to the ascending aorta, perfuses the coronary arteries. And if you see this slide, it very elegantly shows that as you unload the LV, you reduce the infarct size. It starts coming down. Now, putting the device, everybody's aware. I'll skip this, so we'll not waste too much of time. Now, let's look at certain things which were being discussed. So these are important markers angiographically, which you'll see. The Impella motor is seen in the ascending aorta, and the outlet area with the optical sensor is just below that. You have the cannula, you have a radio-opaque marker. This marker has to be at the level of the aortic annulus, and this is what Anil was showing, that you put a pigtail and you form a mental image, and you know that the radio-opaque marker has to be there. The inlet area has to be at least 3.5 centimeters below the aortic annulus, and this is where the device is going to function optimally. So if you put a device in the stable position, then you tick all the boxes and things are going to be just fine. Now, I was mentioning there should be no slack in the device, and echo plays a very, very important role. Now, if you look at the echo, how does echo help? Plaque's view is going to help. This is the aortic annulus, which is marked LA, mitral valve, and the LV. Now, many a times you need to do echo, and you must get into habit of doing the echo once you put the device. A lot of times the device goes a little posteriorly, and it gets into this between the papillary muscles because the initial wire has been in the wrong place. And if the device gets into this place, your Impella is not going to work optimally. There's going to be a suction effect. I'll tell you what suction is, but the device, you must ensure that it stays in this position. And if you see this is the cannula. This is what is called the teardrop. Teardrop is where the inlet of the device is located. The terminal pigtail inlet is just proximal to the teardrop. Now, this is how the device has been put wrongly. If you see this Plaque's view, the device goes into the papillary muscle. So, and if you put it in this spot, you will get suction effect. I'll tell you what suction effect is. So the device, because the wire had gone through the papillary muscles, the device is situated now in the papillary muscles. Correct? The Doppler is also very helpful. Now, when you put a Doppler after the device has been put, a correctly positioned device will show you the Doppler flows at the level of the aortic annulus. That means the blood is coming out here. If you get anything which is suggestive of aortic regurgitation, that means if you see turbulence below the level of the aortic annulus, you have a device which is incorrectly positioned. That means your outlet is little below, and the blood is now being forced out at the level of the aortic valves. Now, this is bad because this is going to lyse the blood, and you're going to have lysis, and the hemodynamics are not going to be optimal. Now, this is the device in the papillary muscle, and you see that there is a lot of turbulence which is happening below the aortic valve annulus, and this is how it appears in a wrongly put device. So the device has to be in the optimal position. Now, let's look at the display section. So the device is now operating at P9 level, and let's see what all you get to see. You see the aortic and ventricular signaling, the ventricular. Now this, I must tell you here that the ventricular trace which you are seeing is not from the sensor. There is no sensor located there inside. This is system derived. So the system, these curves are system derived, and they are not because of acute sensing of ventricular pressure. Now, the motor current basically is a marker of ventricular contractility. If the ventricle is contracting, you will see pulsatility. That means you will see a rising and falling curve, and you'll see a difference in the motor current. If the motor current becomes flat, that means the ventricle is absolutely not contracting because of various reasons. So the motor current is absolutely flat. And this is what shows you the Impella flow rates. Here, the maximum is 6, 4.5 in the mean rate. The current rates are about 5.3 liters per minute. Now, if you have very high inlet LV EDP and the lower aortic pressure, you get something like this. That means there's a complete flat curve, and you see the motor current. Motor current has become absolutely flat. You know, that means there is very less pulsatility which is happening. Now, if you put the outlet also into the ventricle, you will get a ventricularized trace. So this is the aortic pressure trace, which has now become ventricularized. So your trace is, ventricular trace is, you see in the inlet and the outlet part. And if it is in the aorta, if both the rims are in the aorta, you see this. And how does one know? You will see in both of them a flat motor current. There is absolutely no pulsatility at all, and there'll be a complete lack of any pulsatility in the motor currents. That means the device is not optimally positioned. Now, flow rate, as I mentioned, is determined by what you select, and it's the P level which determines. For the first 3 hours, the device is going to automatically select the flow rates, and later you need to adjust. One should never go below P2 levels because the motor will not generate enough pressure, and there can be instances of stalled flow or reverse flow. And one should not climb very rapidly. If you climb very rapidly, there is something called a suction. That means the pump will be rotating so hard, and there won't be enough blood in the left ventricle to be thrown out, and this leads to suction effect, which causes hemolysis. There is damage to the RBCs, and there is a problem. We often talk about cardiac power output, which is nothing but the mean arterial pressure multiplied by cardiac output divided by 451. Now, you don't need to do any of these calculations. The system is going to generate and it's going to tell you what the cardiac power output is. The only thing which you need to remember is this has got a tremendous prognostic value, and the normal range is 1 to 1.5 watts. If the cardiac power output is less than 0.6, the mortality is going to be almost about 50%. Correct? So you need to be very, very cautious, and you need to do things to see that the cardiac power output is maintained. Your display is going to, the Impella display is going to continuously tell you about what the cardiac output and the cardiac power output is there for about 8 hours or so. Now, we talked about the single axis approach. Now, the two focal points at 10 and 2 o'clock position are where you can puncture with a needle. And once you puncture with the needle, you can put in a wire and you can take a 7 French sheath easily. It accommodates 7 French sheath, but not a sheath bigger than that. The caution here is that you must hold the Impella device and then insert the sheath and the guiding catheters. It should not happen that they interact with each other, and it can lead to a little displacement. And I mentioned earlier also, you need to secure the device well, because there should be no slack. If there is a slack in the device, then what happens? The Newton's law comes into play. The pump is going to push the blood out, and when the blood is being pushed out, the catheter will dive into the LV. So you need to secure that. And then you can, at the end of the procedure, remove the companion sheath and secure the Impella catheter. Well, I don't want to dwell too much of time. One of the complex cases, which, we did rote ablation, and you see complete VA uncoupling. So you see a flat line of the pressure trace during the procedure, because the LV absolutely, there was no pressure being generated, but the patient is absolutely comfortable, and that's the beauty of this. And this was, we finished the all complete revascularization we did. We opened up the RCA, we did the left main, and we finished. Yet another case with the sole surviving vessel with the CTO RCA, and the same was done. We did a crossover, didn't attempt LED, which was absolutely non-viable, and then finished the CTO RCA big vessel on the support. Now, once you've done the angioplasties, you need to transfer these patients to the ICU. Now, you can remove the peel away sheath and slide the repositioning sheath into the place, and you need to secure it with the silk threads so that there is absolutely no tension and the device is absolutely fine in its position. While transferring the patient, the device is in place. Be careful not to pull the Impella catheter, because the position can change. So you need to do not prop up the patient more than 30 degrees. And you need to take care that the catheter should not move from its position. You can use a knee immobilizer so that the patient doesn't flex the knees and maintains it straight. Keep checking the urine for hemolysis, because the suction effect can lead to hemolysis, and this will manifest in the urine. You need to access the groin side. There shouldn't be any hematoma. Check the distal pulses regularly. You can entrust the team to be, there's a need to put some gauze pieces behind the input sheet so that it doesn't displace. You should prevent kinking of the purge tubing, because purge is very, very important in maintaining the health of the tube. And ACT all throughout has to be maintained between 160 and 180, because if you don't do that, the pump is not going to work. Now, some troubleshooting points. So this is a busy slide, but I'll go into the individual ones as to where the problem is. And invariably, you need to reposition the device in the ICU, which can be done in the echo guidance. So echo is very important. So next time when you all put a device, you must orient yourself in the plaque's view of the position of the device. And this is equally important when you shift these patients to the ICU, so that once the patient has been shifted, you do one echo at bedside in the cath lab and do a repeat an echo, and this is foolproof. This will tell you, yes, the device has not moved. Now, device is kind of sensitive to preload and afterload and the position. preload is very, very important because I tell you, as I mentioned, the device is going to suck blood out of the LV and throw it out. If your preload is not well maintained, there's going to be problem. The device is not going to function optimally. And the afterload is equally important. You must adjust the afterload. If the afterload is very high, then also the support to the coronaries is not going to be fine, because you'll see some good pressure tracings, but the coronary perfusion is going to be affected. Positioning, of course, is important. Now let's look at the afterload. The goal is to maintain 60 to 80 of MAP. And as I mentioned, if your afterload is high, the Impella flows are going to be on the lesser side. So this what you see in patients with chronic hypertension or use of vasopressors. And if you're concurrently using VA ECMO, that means the patient has come with flooded lungs and is not oxygenating, or has got associated right ventricular failure where the oxygenation isn't getting affected. So you put Impella is what we call. So that is important. Now, where preload is concerned, you need to maintain CVP above 10. Now, this is very, very important. So it is always advisable when you're doing cardiogenic shock or a chip case, it is always advisable to always put a Swan-Ganz. This is one point which I always highlight and tell everyone. Swan-Ganz is very, very important because this gives you a real-time pressure trace from the heart, from the right side of the heart, which is equally important. Now, if the unload, if the preload is not adequate, that means many a times we have these patients with poor LV function, we don't give them fluids and we get them dehydrated. So there can be a suction effect. That means the LV is absolutely underfilled, your IVC is collapsed, and then the device is not going to function and you'll keep getting suction alarms. Now, this invariably happens, as I mentioned, fluid deprived patients who are on diuretics, continuous dialysis. I experienced in my last patient, he was on continuous hemodialysis and we got a lot of suction alarms. So we had to pump in fluids before optimal functioning happened. If the groin or any other source of bleeding is there, or there is RV dysfunction, this is going to happen. So always give a fluid challenge. And this is a very important point. When you give fluid challenge, if the RA pressure is less than 10, you should monitor the increase of cardiac output, and it should go up by 10%, or the right atrial pressure should rise by less than 3 millimeters. So this is very important. So you've given a fluid challenge, and the RA pressure should not go up. Why? Because this is first sign that he was fluid deficient, and despite your fluid challenge, the RA has absorbed the increased quantum of fluid which you have given. So please check on the preloads if your device is not working. Please get into a habit of putting a SWANS whenever you're doing, and you should always echo-wise rule out RV failure. Now, the indicators of RV failures are that you see a dilated RV with a septal bulge, or PAPI scores are less than 1, or the RA pressures are more than 15 to 20. Now, this only SWAN is going to tell you, because you need to have SWAN in place, or you have RA by the capillary wedge pressure more than 0.7. How do you overcome that? You can reduce the PEEP of ventilation if the patient is on ventilator, add a little bit of inotropes, inhaled pulmonary vasodilators. I have never used them in my practice, so I can't say that. And if the patient is far advanced and is because of ACS, you can add ECMO or you can do RV Impella. I have done neither of these. So adding inotropes kind of helps, and beyond that, I have not tried. So this is what is recommended in the literature. So I thought I'll share with you all. Positioning, as I mentioned, check echo in the cath lab, check echo once you've shifted the patient, maintain the inlet 3.5 centimeters below the aortic annulus. The migration can happen. You must use the knee immobilizer. I've kind of mentioned all these points, and repositioning can be done in the CCU itself. You don't need to get the patient out, reduce the P level to P2. Don't do it in the concurrent P levels. Don't move the device. You should reduce the flow rates, reposition the device, check on the echo, and then go back to the previous P levels. Now, suction is something which I've already told you. This happens when the LV is not full. There is preload reduction, patient over diuresed or fluid deprived, or has come back after hemodialysis. What looks like, because the flow rates are less, you'll get suction alarms. The flow rates are lower than the expected. The mean motor current you will see has reduced. So there is no pulsatility in the motor current, and the pressures are going to be on the lower side. So you should assess the volume status, give the volume, and as I mentioned, as you give the fluid challenge, the RA pressure shouldn't go up by more than 3 millimeters of mercury. You can have the thrombosis of the pump. Now this basically, you will see a very high or fluctuant motor current, hemolysis in the absence of suction alarms. If suction alarms are there and hemolysis is there, that means the patient is fluid deprived. And if you get hemolysis despite there being no suction alarms, that means the motor pump is not working at all. You need to replace the pump, and there is no two ways about it. Now, limb ischemia is an issue. Now, this you can overcome if you have the peel away sheath in place. This has got a side port. You can do an antegrade puncture, and this is very easy. You can put in a sheath and connect to that, or else you can do a contralateral puncture and connect with another antegrade puncture. The third thing which you can do, if you've taken out the peel away sheath and there is no side port available, then you can put in a sheath and take a catheter, connect to it, and put it on the contralateral side. Now, these are important things, and you must know how to do it, and this will be kind of your savior. And this is particularly important in patients who've got mild peripheral arterial disease and patient is not able to tolerate the larger sheets, 13 or 14 French inside. Hemolysis, these are the criteria. I don't want to go into the theory. I've already dealt with it. You need to be sensitive. You need to be keep checking that they should be avoided. Now, at times, patient while on Impella can have arrhythmias. You can initiate the defibrillation. There is absolutely, you can also do the CPR as per the hospital protocol. All you need to do is reduce the Impella flow rate, recheck the position, and with the echo, and you can use the defibrillators or whatever you have to do, because or you can do the CPRs. So life-saving is much more important. The Impella is, even if it moves a little, you will be able to repositioning. Now, weaning is something which is very, very important. So before I close, I'll tell you about weaning. Before you decide to wean off, the patient should be either on no or low dose inotrope. It's not a bad idea in a borderline pressure patient to start some inotropes and give him a little bit of inotropes. Now that the revascularization has happened, the vessel is flowing, that can be a help. If the patient is intubated, the FiO2 should be less than 40, the same criteria which they use for extubation, and the PEEP pressure should be on the lower side. The systolic blood pressure above 90 with the aortic and pulmonic pulsatility maintained. The RA and the PCWB pressures have to be normal. Lactase, as was elegantly demonstrated by the case presented, should be on the lower side. Now, RA-LV size should be smaller, and they should be reduced MRTR. And now, hemodynamically, what are the things which we are looking at? We are looking at stable mean arterial pressures, which is very, very important. The second thing which you look for is the crossover. The white curve is the native pressure. So the native pressure should be going up, and there has to be a crossover. The green is the pump-derived pressure. So the Impella flow is about 1.8 and the native flow is 3.1. You know that the native heart has not taken over, and the pressure crossover has happened. You also have to demonstrate that there is stable cardiac power output. That means the cardiac power output is about 1. I told you 1 to 1.5 we maintain. So as long as the cardiac power output is fine, all the three hemodynamic criteria are being met. You see the level, it's P4. How does one regulate? So there is also pulsatility in both the circuits. You check for that, and that is very, very important. You see a very nice pulsatile motor current, and you see the pulsatility of pressure. So this is very, very important. Now, you should, as I mentioned, you keep reducing the flow rates. You were at P8, and from P8, you gradually keep coming down over the time. I'll tell you how the time is determined. And you should not reduce below P2 level until just before removing the catheter, because there can be flow reversal, which can happen. Now, how does one reduce? If you follow the IFUs, the IFU says that from P8 or P9, by every 2, you can come in 4 hours to reach P2 level, or you can come from full support to half support over 2 hours and then go to P2, or you can go directly from full support to P2, never go below P2. So these are different options, and they are going to be dictated by the LV function. They're going to be dictated by the hemodynamics, the previous criteria which I mentioned, that means stable mean arterial pressures, the crossover of the native and the Impella flow rates. And once you reach P2, you should observe hemodynamics for at least 2 hours. If that appears a little longer, maybe 2 hours or so. And then thereafter, probably you can wean off, and it's not a bad idea to leave the, take out the device. Now, if you follow the IFUs, the Impella CP can be kept in place only for 5 days. So this is what IFU says. People have kept it longer, and I think Sanjeev was mentioning about 28 days. But you need to be very careful because the chances of limb ischemia, DIC, and the coagulation or the cerebral stroke rates increase because this is a bulky device and it can cause a lot of problem. Well, to conclude, I would say that increasing number of chip cases and delayed presentation of AMI with cardiogenic shock are there around us, requiring MCS devices. The choice of device is to be tailored by the patient's need in terms of the hemodynamics, the anatomical features, the physician competence, and the availability of device and the economical background. Now, the last two components are very, very important. Many a times, the family agrees, but the device is not available because it's an expensive device. And many a times you feel that the device is going to benefit, but the patient and the family in the civil street is going to mortgage his property. So everything is left to the conscience of the operator as to where what to be selected. But there are certain virtues which Impella possesses amongst the available MCS devices, which are quite unique, and they kind of make it a simple device which works all around by providing LV support, circulatory support, reducing the LV, unloading the LV, and maintaining the coronary perfusion. I thank you all for your patient hearing. Sorry if I exceeded the time.
Very lucid, sir. Very, very lucid. I think wonderfully presented. But the more
Sir,
important...
I have a question, sir.
Please. I am not able to unshare.
Sir, should surgeons be using more Impella then instead of their usual go-to VA ECMO? I mean, I find that a lot of the times it is the LV which is failing post a bypass surgery, and should therefore surgeons be getting onto the Impella board as well?
See, the issue here is, Sanjeev, the cost which is involved.
So
the cost of ECMO is, if you have the circuitry with you, is not so much as the cost of Impella device. And you correctly point out that I showed you on that slide that the ECMO is essentially meant for RV support if you have a biventricular failure, or otherwise it is essentially meant, it's an oxygenator, your lungs are failing. That means because of the heart failure, your oxygenation is getting affected. So there's a biventricular failure. So there the ECMO comes into play. But if you use ECMO without Impella, you are increasing the afterload on the heart because the blood is being injected back into the aorta or into a large artery, which leads to increase in the afterload, and that can lead to, infarct, extension, or injury to the cardiac muscle. So your point is very valid, but there is cost which is involved in this.
So I mean, armed forces still cost comes a little low down. We can argue for people. I was just looking at, sir, a patient-centric approach.
No, scientifically, if you are talking, you are absolutely bang on and you are on spot. But having said, armed forces is different in RNR and armed forces is different in the periphery.
Agreed, sir. That is a given, sir. That I agree, sir. Sir, the second thing was that is there any lactate level which decides for you that you are not going to use Impella in this particular patient? And I speak purely from the experiences with cardiogenic shocks.
So when the device was first launched, and they were, Biomed was pretty stringent, and they would ask for, what does lactate levels mean? Lactate levels means that there is multi-organ dysfunction. And even if the heart is going to recover, the other organs might not recover, and this will be a wasteful expenditure. So Biomed, if you ask them, if you would ask them for a device, the first thing they would ask is, what are the lactate levels? Fine. So this is more in an ACS cardiogenic shock milieu, not for the chip cases. Correct? So having said that, if a person has got already, multi-organ dysfunction, he's kind of, you don't know about the brain function and the other organ functions which are not functioning optimally, this sole insertion of this device is not going to bail him out. But in chip cases or in transient LV dysfunction, this device, by virtue of the hemodynamics, has reversed lactates in a lot of case scenarios. So I will leave it at that. We cannot use it as a sole indicator for denying or for implanting a device. But it has a more role to play in cardiogenic shock post-ACS milieu than in the chip environment.
Great.
Wonderful. I mean, what I want to convey out of my talk is that, like I have been saying this for imaging, it is always nice to get behind the things, So it is always nice next time on when you have a Impella insertion, spend some time with the company rep who comes. He will educate you tremendously about what is happening, how he starts, and what is the role of each component of the device. You will gain a lot of confidence in using. You'll get a lot of confidence over a period of time in correcting some or troubleshooting minor things which are happening post shifting, because the help is not going to be around for a longer time. So same thing goes for the imaging. Till the time you stand behind the machine and play with the buttons, you don't learn it. So you must do the same with the Impella device. Wonderful. So I think it's been a long evening, and I think I have exceeded the time.
Sir, can I ask one question just?
Please, Anil.
So, sir, as I showed our data, the experience with complex PCIs has been great. I mean, the mortality rate, as I showed, sir, and there are patients who are still on our follow-up and they are doing well, even 1 year down the line, 6 months down the line. But unfortunately, the same can't be said for those patients who come with, let's say, ischemic cardiomyopathy, cardiogenic shock because of some other reasons. There, the experience has been the complete reverse. I mean, 5 patients, none of them survived, sir. I mean, short of transplant, I don't know still what to do for these patients.
So Anil, the same is the story in clinical trials. Danger shock was the first randomized trial, and even there, the mortalities are very high. So this is universal fact for the cardiogenic shock subset, that the mortalities there are going to be on a higher side compared to the
ones who can be revascularized.
Which is because
I mean it stands to reason also, yes, sir.
Yeah, absolutely, absolutely. So danger shock was the first randomized trial which showed benefit to the absolute reduction of mortality by about 10% vis-a-vis the standard therapy. But the other message out of danger shock, which we should be, the company celebrate saying that, oh, very nice, it's a win-win. But the other message out of danger shock was that it pulled the device down by virtue of the peripheral complications.
Yes.
You have to do a very neat job with the peripheries, So that is very, very important. The bleeding risk, thrombosis, the arterial injury, all that is very high with.
Yes. In fact, sir, one of our post-CABG patients, we post-CABG, then he had a Lima graft blocked. We opened up the LED in the night. Professor had done that case. The patient was not improving. Despite that, we put a Impella. Thereafter, he ended up with a limb amputation. He finally died after a misery of around 3 weeks or so, sir. It was a very, very...
yes. This is well documented. Sir. This is a well documented, complication of Impella, because it's a large bore axis device. Sir. And if you leave it for longer times, there are going to be problems.
Sir. It was the Tofso patient, I remember. Am I right?
Yes, sir. Yes, sir.
Sad, very sad.
Namrit is omnipotent, omnipresent.
Yes, I'm just
thinking. Very nice talking to you all. I think we can stop here with the permission of the senior most serving officer of Armed Forces Medical Services, or AMC. Brigadier Navreet?
Sir, non-functional.
No.
The functional one is someone else.
It was an evening very well spent. I really enjoyed, and reconnecting with
Thank you, Viva.
a
I
lot of
think
old friends. I'm seeing Ratish after 1 year,
Yes.
and I can't use unparliamentary language here. You better call me back. Okay.
learn from you.
Okay. Thank you. Thank you, everyone.
Thanks a lot, sir.
Thank you, sir.
Thanks a lot, everyone. Have a wonderful evening ahead. Thank you.
Thank you. Thank you. Thank you,
Evening,
Viva,
Thank you,
for
sir.
all your
Thank you.
effort. Thank you.
Thank you,
Thanks
sir.
a lot, sir. We extend a heartfelt thanks to each one of you.
Thank you.
Thank you.
Bye. Good night.
Good night.
Good night, everyone.